So, sort of going in the order of things, we had said to them last week right away the first thing we need to do is we need to set up ante rooms or separate areas where we actually triage patients when they come to the hospital. Normally, people would come to the hospital electively or they'd come through an emergency department. We don't want that to happen, right? So, if we're somebody coming to the hospital, we want you to go into that tent or to that ante room, have some staff that have PPE, meaning proper equipment on, don't and doffed, be able to check you out, ask you the right questions, find out if maybe you're somebody we suspect with COVID. And if that's the case, if we suspect you are, it might be that we say to you, you know what, you're relatively healthy, your symptoms are mild, go home, self-quarantine. If for some reason you have other symptoms and we need to put you somewhere inside inpatient facility, our next recommendation is that we designate floors within the hospital, as well as potentially some specific hospitals, which would be really good, to be COVID patient specific. And we want that because there's only so much supply of protective equipment right now. Whether we like that or not, it certainly isn't the way the reality of the world should be, but it is what it is. So if we're going to be smart about it, they're going to make sure that we properly staff a unit where the COVID patients are and give those staff all the proper equipment that they need. And if we don't mix the patient, it means that the staff can put on the equipment once and continue to wear it. If we mix the patients, I have to be extremely careful that if I go into a COVID positive area, that I don't doff that equipment before I go into the next area because I don't want to actually expose the next patient. So we need designated units inside the hospitals and potentially, I think realistically, whole hospitals themselves for the expected surge that we're going to see. Right. Well, at this point, I think if a nurse is suspected had been in contact with a COVID patient and we want that nurse quarantined, the issue that's going to arise is whether or not then the nurse goes home and then is among her family member or other people in her neighborhood or community and turns out positive, then we haven't really done anybody much good. So what we're really suggesting is it would be wise for us to look at actually getting designating housing space for two categories. One is a nurse or healthcare worker that's suspected that we want to quarantine, make sure they're not positive. We give them housing if they need it. If they don't need it, fine. If they're going home alone or they have a particular setup, that's fine. But we should have it available to them. And for the second group of people, for the nurses who are going to work with COVID patients and are already, who really feel that they cannot go home safely because maybe somebody in their family is immunocompromised or there's a particular reason, that we think it's also equally wise to have housing set up for those individuals as well. We used the shuttle buses often to bring the nurses from one location to the next, and ironically, that certainly doesn't do social distancing if we're packing everybody onto a bus. So not a wise move. So given the fact that we're really suppressing any visitors, there really shouldn't be any visitors going into the hospitals at all unless it's absolutely necessary. And they should be tested or at least, interviewed prior to going in. So they shouldn't be going if they have a cough or anything. But because the number of people that are normally going to the hospital locations would be suppressed, we think that there's probably the parking space in the parking garages or available areas in the hotels that are available. We really think that probably the nurses should be designated parking areas now. Let's get them in, let them park directly, and not put them exposing one another on a squished bus shuttle ride. I think this is one of the most disconcerting parts of this whole issue. And that is, it really should have been happening much more quickly and widespread. So when I say widespread, I mean every healthcare facility, whether it's a doctor's office, a clinic, urgent centers, whatever it is, really we should not be seeing any patients that are non-essential. So if you were going to go to a clinic and have some mold taken off, or if you were going in for some surgery that could be put off a few weeks, it's not emergent, we don't want you in there. I certainly don't think you should be in there. And there's two really main reasons for that. One is if you went in and the reality is things didn't go well, the expectation fully would be you'd be transferred to a hospital with an available bed at the same time that we're trying to free up these beds for a surge in the pandemic. So no, we don't want you potentially using up a bed. Let's put off your elective surgery till after this is over. And the other thing, to be frank, is if there's available equipment inside these facilities, whether it be protective equipment or whether it be other types of equipment like ventilators, if you're going to have a surgical procedure, we don't need those in outpatient facilities right now. We need those designated for the facilities that are going to be taking care of the surge of COVID patients. Again, I think this is somewhat frightening for people right now, but I would say this, it doesn't have to be a panic situation. You know what I mean? The thing is, the group that has the biggest control, more so than the healthcare workers, to actually basically tamp this whole thing down is the public themselves. And that is by self-quarantining and really shutting down any social interaction. And that sounds awful to say, I know. And, you know, it's going to be extremely hard to do because it's not in our nature. But the reality is, I know if I'm young, or I'm not that young anymore, but if I'm healthy or whatever, and there's young folks out there that may be really mildly symptomatic, I get it. I'm over it. It's not a big deal. But the problem is, who am I giving it to? Because if I go see my elderly parents, or if I go among other people and I don't think anything of it, and that person is going to become severely ill, as we know 10 to 15% of the population will, and may not survive, it literally have been on you to have put yourself in a situation to enjoy yourself on not having to work or a social interaction that little did you know you actually gave somebody a virus that we could have avoided having it. And at least even if they did get it, by slowing it down, we gave them the best shot of having an available bed, available personnel, and available equipment to get them through the crisis so they got out through the other side of this healthy. So the two components that I would look at, one is in the sort of microcosm of things where we're asking everybody to shut down their elective surgeries. And the reality is we sort of have a business model set up, and if we ask them to do that and their revenues decrease, then suddenly they say we don't have enough revenue to pay the staff now. We're going to have to furlough the very staff that we desperately need during the surge. So we do have to have a mechanism to staff, to revenue up, if you will, the period from which we're asking folks to clean out, make their hospitals a ghost town right now, and then basically pay that time as if it were full, so that we have them as a ghost time, and yet we have all the staff on board and we are fully prepared for what's about to happen. So that's the first piece of it. The second piece is, given that we were unprepared with the equipment that we needed, and that is as it is, that we know. The problem is, what are we doing about it now? Well, now it's incumbent upon us. Okay, we weren't prepared, but that doesn't mean we shouldn't get prepared. So if we have, you know, between the United States, Canada, Mexico, as a North American group, I cannot believe that if China can build hospitals in 3 weeks, that between our three countries, we can't manage to put together all the protective equipment we need and start making ventilators as fast as possible. If we can build warplanes for war, we can certainly build ventilators to save patients.